Well, I want to thank you again for the opportunity to be here again with such a distinguished panel and to be with you. I'm particularly pleased to be invited to talk about this topic. I think you know by now I spend my life and world really on accreditation issues. And accreditation, of course, is more than just regulatory and more than just ensuring that the students are being well served and the public is safe. It's really a continuous quality improvement process. And so over the course of the 7 years that I've had the honor to serve the Liaison Committee on Medical Education, I visited well over 100 U.S. and Canadian medical schools. And when you go in as I am an accreditor, you get to ask any question you want, and they have to answer. And so over the course of those many visits I've had, and I will tell you, every school I visit, I learn something new. And so several months ago, one of the groups in the United States said, well, Dr. Hunt, since you've been around in all these schools, why don't you tell us about some interesting curriculum things that you've seen? And so I put together a talk, and using the kind of David Letterman, or I don't watch those night shows, but whoever does the top 10, I did the top 10 of medical education curriculum innovations that I've seen on my travels. And so I'm going to give you the top 3 in respect for the time, and also, to me, they really are the top 3. Now, when I did the top 10, I would have a little drum roll between each of them. So I may need your help on this one. I may need you to thank you as we move through. But I decided to choose the first 2 based on a quiet revolution that is going on in the United States in innovation of medical education. And I call it quiet because it's not very visible from the surface. It's not a new simulation lab. It's not a new way to do admissions. It's not a new way to instruct, problem-based learning, case-based, flipped classrooms. Those are all really important and very visible. But this is a very quiet revolution that I actually think is more important than all of those things that I've said. And it stems from the accrediting body's demand of the U.S. and Canadian medical schools that they teach the material in an integrated format. This is the standard. It used to be called ED 33, and we've just revised our standards, so we call it 8.1. Doesn't matter. But it is the most important accreditation standard of all 95. Let me just read it to you. A medical school has in place an institutional body, faculty committee, your curriculum committee basically, that oversees medical education program as a whole, has responsibility for overall design management, integration, I'm going to come back to that word, evaluation, enhancement of a coherent and coordinated medical curriculum. Now, when you see the word integrated, it's not just integrating basic sciences and clinical sciences. No, that's not what it is. That's only one small piece of it. It's that this curriculum committee faculty have to know everything about the curriculum. And they have to integrate the content across, for us, 4 years, for you maybe 5, 6, so that it's no longer acceptable in the United States that there be courses really good courses that operate separately. The material has to flow. The faculty have to be able to produce documentation that they can monitor breast cancer over those 4 years of the curriculum. And they can use their outcome assessment and see where their students are weak. Yeah, they're good on breast cancer, but look at the licensing exam information. They're not so good on the chemotherapy side. Let's see where oh look, there's a gap. We're going to have internal medicine in the clerkship give more on chemotherapy of breast cancer. And that curriculum committee has to have the authority to go to the internal medicine and say, okay, you have 2 lectures on diabetes. You're now only allowed to have 1, and you have to do breast cancer treatments because there's a gap. And you're not serving your internal medicine clerkship, you're serving the school. So the quiet revolution is breaking down the disciplines. No more departmental courses. Now they can have departmental courses, but those courses don't have the ultimate authority. The curriculum committee manages and oversees. Now in the United States we're gifted and blessed with resources. Every school is required to have an effective electronic management of the content so that with a push of the button you can see all the teachers of hemolytic anemia and see who teaches what in nutrition and how that flows over the 4 years, and that's how they manage it. So that's just going on now. Every school is doing that. But I decided to give you 2 examples of some really cool integration. And so, are we ready? Putting the pieces together the El Paso way. So right now, I will bet you that this is how your curriculum looks like. You have a really good course here in biochemistry. And right over here, you have a great course in cardiology. Let's do here. This is anatomy. They learn about the mitral valve in the first year. And then in the second year, they learn, or later on in the first year, they learn how fluids flow over surfaces in physiology. And then in the second year down here, they learn about bacteria that's set up on a mitral valve that has a problem. And over here, then about 9 months later, they learn about the type of bacteria that's set up on a deformed mitral valve. And then maybe over here, 6 months later, they learn the pharmacology of a mitral valve prolapse and infection that's going on. That's what curriculum has been. And so the innovation that I like that a new school, the Paul Foster School of Medicine, Texas Tech, El Paso, one of the 18 new schools that have come online in the United States in the last 7 years, is they start with what's called the schema. Now, we have to tip our hat to Calgary up in Canada, because they actually came up with this concept and first put it in place probably 10 years ago. But they start, first off, they identify, in Calgary's case, 100 clinical diseases, and we're going to talk about clinical presentations, and we're just going to use the example of sore throat, one of the 100. El Paso, I think, uses 110 because they wanted to make it their own. But they start off with what's called the schema. And the schema is just simply the diagnostic differential thinking that a physician does when she sees somebody presenting with a sore throat. Let's look at the sore throat schema. So somebody presents, I have a sore throat, doctor, and you go through your questioning. Is that the primary problem, or are you having any problems with your sinuses? Are you having any earaches? No, doctor, it's mostly a sore throat. I don't have really much sniffles. Okay, well, how long has it been? Well, it's been 2 weeks. Oh, okay. So if it's longer than 2 weeks, you're going to start thinking about possible structural problems. If it's this, it's primarily probably infectious. And if now you're going to do your little different, and now you're working through, is this viral, is this bacterial? So basically, they designed the schema or the differential diagnosis that you would do on the history taking for each of the 100 clinical presentations. The schema, so keep that in mind. And now, they designed the curriculum around the schema. So here we see the 9 of the 12 basic disciplines, basic sciences, that go into understanding the sore throat. And the faculty work intensively together. Each one of the people around this table represent a different discipline, biochemistry, physiology, and they put the puzzle together themselves on what does somebody need to know to understand a sore throat. And so they put all the basic sciences that you're teaching into the context of how the student will be in the future asked about this information. You see, one of the problems that we do now, we give the students the information in structures of basic science. Or even if you integrate it and use organ systems, you're still giving it to them in a structure that is unlike how a patient presents. And that's why if you're teaching on the wards and you get the student in your 4th or 5th year and you ask them to talk about sore throat, you get this blank. And you ask them questions and you say to yourself, well, what did they do in the first couple years? Didn't they learn anything? Well, they did. It's just that it's all locked away in a different structural format in their mind. So this system puts all that basic science in the structure that they're going to be asked about. Okay? So let's look at a typical week. Now, you can't see this. I appreciate that, so I'm going to walk you through the week of the sore throat. So every clinical case has a week. This is early in the curriculum. This is the third week of medical school. This is a school that does a post-baccalaureate, so they start after the student has the bachelor's degree. The first hour is they get feedback on last week's clinical case. And then they get the conceptual framework. So they go over that diagnostic model that I showed you. And then they get the anatomy of the pharynx, a prosection of the throat and mouth. You see how the basic science now is lining up with the way they're going to be seeing it in the future? Now I get questions on this. Well, but how do we basic scientists teach the nervous system? How do we teach basic immunology? Well, it's done in this context. So this is still very early in the curriculum. And so the neuroanatomy of pain is actually going to start the overview of the nervous system, but it's always referring back to the clinical presentation. So as they talk about pain fibers, they're associating it with the sore throat, but they're teaching the basic neuroanatomy. And then the immunologist comes in and starts a basic talk about antigens. He comes back over here and talks about lymphocyte maturation, but it's always in the context of a clinical case. The acute inflammation, it carries on, and here we see, here's the pharmacologist coming in here, pharmacodynamics, what drugs do to the body. So he's going to start half-life now in the context of the sore throat, and probably uses his examples, the kind of antibiotics you might use in a strep throat situation, teaching basic pharmacology. And over here, and then the clinical skills, the physical and the history taking occur that afternoon. But here, you're going to love this. Look at the last thing on Friday. How to take your history for the sore throat in Spanish. Don't you love that? All right, what's that? Yes. So, yes. Number 2. And this is going to be a little shorter, so we're going to be okay. Visualize a curriculum that doesn't have any clerkships. Now, I hope the word is translating to you, because you should all be saying, is he doing science fiction again? By the way, one of you complimented me so kindly yesterday when I projected medical education in the future. You said, you're the Jules Verne of medical education. My wife loved it. Science fiction. This is not science fiction. When we put our students into their 6 weeks of medicine or 12 weeks of surgery or 6 weeks of psychiatry, are we very surprised we don't get people going into primary care? I mean, we give them to the specialists. Are we surprised that they don't form humanistic relationships with the people they see? No. When you're only with medicine for 12 weeks or 6 weeks, whatever yours is, you don't get to know your patients. All you see is the presentation of a disease. So I give you the longitudinally integrated clerkship. It's available in Australia, Canada, and the US. I don't know that it's anywhere outside of those 3 countries. There are examples for rural settings and urban settings. You basically, it's not as hard as it sounds, but it's not as simple as I make it. You identify, all your disciplines identify the clinical situations that every student must see, and you must monitor that very closely. You identify the learning objectives that every student must have at the end of their clinical experience. You then put the student into a multidisciplinary type of clinic for a year, and they keep track on a daily basis of the patients they're seeing. The Cambridge system in Boston is an urban model. They use a panel of patients, so I would have about 400 patients assigned to me that I follow over that year, and they pick the types of patients carefully. They choose a fairly severe asthmatic child, so they can follow that child into the emergency room, into the short hospital stay, and back into home again, so they understand that particular clinical presentation. They have several diabetic type patients that they follow over the year. They see patients in clinic, but when the beeper sounds and their asthmatic child is in the ER, they go. So they follow these patients. Now in the rural settings, small settings, you can get the same continuity of your patients by simply staying within that multi-clinic setting. And in the course of that year, they get everything and better than what they would do on those blocked clerkships. Now David Hirsch and Barbara Auger have written very nicely. First off, the research is now showing from licensing exams of side-by-side comparisons insignificantly better outcome on licensing exam with longitudinal integrated clerkships. So they're scoring a little bit higher, but the important piece is it's relatively, it's equivalent in terms of knowledge, retention, and clinical skills. But what we're seeing is certainly the students, after they get over the initial, oh, what am I supposed to do? They love it, compared to the students in the same school with the block clerkships. But the 3 most important things that come away from this experience is the longitudinal relationship with the supervisors, because they're working with the same set of clinicians for a year. And you know yourself, when you have a student for 8 weeks on your rotation, you barely get to know them well enough to give them any feedback, and it's superficial, because you don't know them well enough. You spend a year with one of these students, you know how much they can take you, and the feedback becomes more like a colleague. Number 2, because they're following these patients, I'm going to call them individuals, they get to know them as individuals with health problems rather than diseases. Number 3, because they're working in the same system, the urban hospital in Cambridge or the rural clinic in Yankton, South Dakota, They get to know the system. They get to know that you, the clinician, like this physical therapist for that type of knee problem, but you like that physical therapist for the cardiovascular problem. So they get to understand how the system operates because they're in one place for a year. So I really encourage you to look at these two amazing ways to integrate. Bottom line, you got to integrate your curriculum. But here's two really cool ways to do it. Now, one more. Because those two curriculum innovations are very challenging, I was a curriculum dean for 17 years, and I know how, well, let's just say not particularly easy to change my faculty were. And as I was putting this talk together, bingo came to mind. So Susan and I, prior to moving to Washington, D.C., had a sheep and goat farm. Remember, I'm the pumpkin guy. I like growing things. And Bingo was one of our males, Angora goats, mohair. And Bingo was a stubborn guy. He'd get these horns hooked in the fence, and you really have a hard time getting him out. Now, I don't want you to think I'm comparing Bingo to your faculty. I mean, I think that would be very disrespectful to Bingo. So, because the two changes I've suggested to you might be a little daunting, I've taken one that you can take home right now and put in place. So Dr. Harden is going to speak about the Aspire program, and I am a reviewer for schools that apply for excellence in student engagement. And I came across this school in Southampton, and they give me permission to say this. And I noticed, you all do evaluations of your courses, right? Your students tell you how the lectures were and how the course was. And you know that by the third year, fourth year, it's hard to get them to fill out the forms. Do you have that same problem? I mean, I always did. And I looked at this school in Southampton, and they had a 95% response rate of good information from their students way out into year 6. And I said, how are they doing that? And I dug down, and I found that you said, we did. So what they do is they keep track over the year of all the little changes that they make based on student feedback. And at the end of the year, they write a simple little annual report to each class that has moved on. You said the physiology exam was too close to the biochemistry exam, ... We moved physiology to the previous week. You said the lockers at St. Queen's were not well maintained, ... We have renovated them, new locks, and everybody is happy. And it was like a one-pager. It's all the stuff you do, but you've closed the loop, and that way you get the feedback. So this one you can take home. I wish you well. Thank you.